Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. You tuned into Inspired Afternoons with me, your host, Maryam Mia on Salam Media. And our next, we have a health segment. Your health is your wealth. That's my motto. And we'd like to acknowledge Path 24 Laboratories for sponsoring this consumer information medical segment. And today we're speaking blood disorders, and we're going to be focusing on low blood and anemia. And I have joining me um, Professor Muhammed Karodia, and he's a clinical hematologist from Path 24 Labs. So let's welcome him. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, Professor Muhammad on Salam Media. And how's your fast going today? So far, all good?
Walaikum assalam wa rahmatullah. Mariam, Jazakallah for the opportunity. So far, so good. We'll see how this goes.
Okay. I mentioned that this is a consumer information segment because, when it comes to the medical fraternity and medical terms in it, it's so vast. And sometimes, people will say you visited this specialist and that specialist. And then just not to sound ignorant at the risk of sounding ignorant, people just assume, oh, we understand what you're saying. Or somebody says, I'm suffering from this condition, and then you just nod and you don't know, and maybe 20 minutes later as you're leaving you Google all these things, and sometimes Google is not very factual. So let's start by your title. Before we start, what is a clinical hematologist? So when would I need to visit Professor Muhammad Karodia, who's a clinical hematologist?
Hopefully, Appa Mariam, hopefully you don't want to visit me and you don't need to visit me.
Inshallah.
But on a more serious note, no. So clinical hematology essentially is the study and the treatment of blood disorders. Now, blood disorders is not as simple as we just think to do with red blood cells, white blood cells, and platelets, but of course also to do with cancers associated with the blood organs or the blood forming organs. So the leukemias, the lymphomas, the multiple myelomas, and sometimes even some of the immunological disorders, patients with immune dysregulation or autoimmune diseases sometimes will also be dealt with by the clinical hematologist.
Shukran for that. So now let's dive right into that. So understanding blood disorders. And while we're speaking, the first slide will come on understanding blood disorders.
So, Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatan min lisani yafqahu qawli. Rabbi zidni ilma. So, it's in this 10-minute segment, it's very difficult to have an exhaustive discussion on blood disorders. But what we can do is try and give a brief introduction to the blood disorders, and I've decided that what we'll do is we'll focus on the anemia. So as you heard, my name is Muhammed Karodia. I'm a clinical hematologist. I'm with Path 24 and also at the Sefako Mukhato Health Sciences University and Dr. George Mukari Academic Hospital. So as I said, what we'll do is have a brief introduction to the blood disorders. And I'm going to focus today on the more common one, and that really is the anemias. So in terms of anemia, really, what does it mean? Now, before we even get to that, let's talk a little bit about how blood is formed. And so the blood really is made up of these three different cells, essentially the main cells, which is the red cells, the white cells, and the platelets. And these cells are essentially produced in the bone marrow, and this process is called hematopoiesis, the production of red cells. And I'm sure all of us have seen bone marrow in a chicken bone or an animal bone, and you see the inside where the marrow is, and that's where the bone, where the blood is really formed. Now, all of these cells have a different function, and a very important function, of course. The red cells carry oxygen, and the white cells fight infection, while the platelets help with clotting. So when there is a reduction really in the red cells, there's a reduction then in the oxygen carrying capacity, and hence patients then feel tired, feel drained, need to sleep in the afternoon, they don't have enough energy. So that's when the red cells are low, and that's what we're going to talk more about today, and that's the anemias. But just briefly, the white cells fight infections and the platelets help with clotting. So if the platelets are low, then patients can bleed. They have bleeding disorders, and if the white cells are low, then you get infections. So let's talk briefly about anemia. And again, as I said, we're not going to go too much in depth. And anemia essentially is a condition where you don't have enough red blood cells and your hemoglobin is then low. And you'll hear your doctor saying your HB or your hemoglobin is low. And we'll talk about the blood test a little bit later in depth. So what does this hemoglobin do? It carries oxygen, and that's its primary function. And it carries oxygen. It picks up the oxygen in your lungs, where this transport, or rather where this transfer takes place. The oxygen that is taken through your lungs when you breathe in, and that is then transferred in the lungs in the small alveoli into the vessels, into the blood vessels, where the hemoglobin then carries this oxygen. And the oxygen is important because, of course, as we say, it then goes to the rest of the body and oxygenates the body. So when you don't have enough oxygen, of course, you can't produce enough energy, and hence you feel tired and weak. And the symptoms, as you see, they are tiredness, fatigue, dizziness, lightheadedness. In fact, a patient came to me day before yesterday and said, I don't feel tired, but my family have noticed I'm very pale. And when we tested her, of course, she was anemic. So paleness of the skin is one other sign, and then the shortness of breath and cold hands and feet. And there are other symptoms. In fact, when it progresses significantly, patients can even go into heart failure. Now, from the anemias, probably the most common anemia, the one that we see most commonly, and in fact, not just in our country, this is internationally the most common cause of anemia, is iron deficiency. And I think the most important thing, there's quite a few things I said on the slide, but really the most important thing, the take home message with regard to iron deficiency, is not really the treatment, is what's the cause. The cause is the most important, because one needs to isolate the cause so that then the treatment can be effective. And even though I've listed there blood loss, poor diet, or absorption problems, really in more than 90% of patients, blood loss is the cause. So we need to look for blood loss. And again, the same symptoms of anemia that we talked about, you see them, but they are more common in women, certainly, more common in children, growing children specifically, where you get a physiological iron deficiency, and certainly even the elderly when they have bleeding problems. So very important is the diagnosis. How do we diagnose it? And maybe a little bit later we can talk about the blood test, Miriam. What kind of blood tests we do, the ones that we offer at Beth 24, so that you can test for the iron deficiency, and how we treat it. We'll spend a bit more time. Then I'm going to talk lastly about megaloblastic anemia, and this is another common anemia, another common cause of anemia, certainly not as common as iron deficiency, but we do see it, and this is as a result of vitamin B12 deficiency or folate deficiency, so folic acid. And patients again feel weak, pale, they have mouth sores. In the case of specifically the megaloblastic anemia, you can have nerve issues. In fact, it can present with cognitive dysfunction, can present with peripheral neuropathies where you can't feel, and numbness. So it's very serious deficiency when it is at its extreme. It's caused by a few things. Pernicious anemia is one of them. And pernicious anemia is an autoimmune disease where your stomach does not produce a particular hormone which is required for the absorption. And in fact, pernicious anemia is the most common cause, and this needs to be tested. Diet absolutely is a cause. So vegetarians may have a megaloblastic anemia, but of note, it takes several years of not eating vitamin B12 rich food. So 5 years at least, some say 5 to 7 years for you to become vitamin B12 deficient. Certainly, you can have it with malabsorption, people who don't absorb well, who have had stomach or gastric surgery, and there's certain medications that can cause it. So again, the diagnosis is very important. It's done on a blood test. Of course, there's a clinical suspicion. Your doctor sees you and is suspicious that you may have this deficiency, and does the blood test. And again, like I said, we'll talk about it earlier. And then the treatment is really vitamin B12 injections. Now, I'm not going to go into the leukemias and any of those other disorders. I think I'm going to pause there rather. Upper Mariam, if you're happy with that, and then perhaps we give you an opportunity, or audience an opportunity, some questions.
Yes, Jazakallah for that. As you're speaking, the focus is on anemia because lots of people nowadays, just socially when you're speaking, they'll say, you know what, I'm anemic, I have low blood pressure, or like you say, people are feeling tired or the family's commenting they look pale. There was a joke, incidentally, they saying females are presenting with a lot more anemia and low blood pressure. So I said, then we need to do some research on the males. Are they probably the cause of the low blood pressure? Yeah. So tell us, when is it cause for concern? So when you go for the test, often the doctor says you need to go for a hemoglobin test. Can you please break down what is a hemoglobin test, and then the results of which, what does it reveal to your medical practitioner?
Yes. So firstly, yeah, I mean, you said that you're hearing very often that people have anemia. In fact, anemia affect about 30% of the world's population. So 1 in 3 people that you meet will probably have an anemia. So when do you take it seriously? One wants to be vigilant, but one does not want to create hysteria, and that's very, very important. And sometimes this is a fine line. So the importance is the symptoms that we talked about earlier, but secondly, a change from your normal. That for me would be something to consider. Of course, one realizes as one gets older, perhaps even less fitter, the ability to do certain activities may be reduced based on that. But if there's a change from your normal, and particularly a sudden acute change, then one needs to consider that this may be abnormal. So tiredness, fatigue, weakness, paleness, you can see that the person is pale, perhaps sometimes even changes in the nails, etc. Those would be suggestive that perhaps there is an anemia underlying. Now, what you can do, of course, once you visit your doctor, they ask you to do a test, and you talked about the hemoglobin, but it's more generally what we do mainly is a full blood count. And in a full blood count, what we measure is really the global functioning of the bone marrow. So we look at the red cells, we look at the white cells, and we look at the platelets. And specifically with regard to anemia, we look at the red cells, and there we look at the hemoglobin. And the hemoglobin, as we said, this is that compound that carries the oxygen. And then below the hemoglobin, we also look at what we call the red cell indices, the MCV and the MCH. And this helps us to try and identify if there is an anemia, what is the cause. And let me explain briefly, if I may, that if the HB is low and this MCV is low, in other words, it shows that the red cells are small, this is suggestive of iron deficiency and other things, but the most common thing is iron deficiency. And if the red cells are large, this MCV is high, more than 100 perhaps, this suggests a megaloblastic picture. So vitamin B12 deficiency is one of the things that will happen, or one of the things we'll consider. But of course, there are other things. But essentially, you're doing that full blood count, Miriam.
Okay, so hemoglobin at 7, what does it mean?
Yes, so that's a very good question. So, what you're identifying really is the degree of anemia, and that's what we're talking about. Because really, the symptoms are often related to a few things. One, they're related to the degree of anemia, how low that HB is, but they're also related to other things. Other things like how quick the anemia develops. If the anemia develops very fast, in other words, the blood loss or whatever is causing the anemia happens fast, then patients become symptomatic more commonly. They feel it, they feel tired. But if the anemia happens over a period of time and it's related to blood loss, as we said earlier, and this blood loss is slow, then the anemia develops insidiously over a long period of time, then the body compensates and then you may not be symptomatic. Other things that are important, apart from just the number, is age. So older people, of course, will become symptomatic more. People who have heart disease, particularly those with heart disease, will be more susceptible to the symptoms of anemia, even at higher levels. And even those who perhaps have brain injury, those are the ones that need to be a little bit more careful. Now, an HB of 7 that you talked about, what we do is we classify it according to the WHO classification. The World Health Organization gives us a classification for mild, moderate, and severe. So an HB less than the upper limit of normal, and the lower limit of normal, this depends on age and gender. So in other words, males have a higher hemoglobin normal threshold, whereas females will have a lower one. But nonetheless, below that level to 10, that is classified by the WHO as a mild anemia. If it's between 7 and 10, then this is classified as a moderate anemia. And if it's less than 7, then this is classified as a severe anemia. This classification changes in pregnant females. In pregnant females, we don't use the 12 or the normal that we normally use. We say less than 11 because we expect that in pregnancy, the HB, because of dilution, will go a little bit lower. I hope that answers that question, Mariam.
Yes, it does. Okay. And I also didn't know that there's a different threshold between males and females, and that maybe we're just stronger and we can take a lot more.
Yeah, yeah. Actually,
So it's
Miriam,
just this tongue
Miriam, I
in.
tell the students that we think males are superior, but actually females are far superior because they need less blood to maintain their brain function, which is probably the most important thing a human has to do. So females HBs has to be, at around 12 is fine. Males need 13. So I think you're
Yeah,
right,
I know
Miriam.
that.
I agree with
And
you.
also, you say brain function, we cannot multitask, we megatask. So, Alhamdulillah, they again, brain function required. So now, Professor, nowadays there's this, I know before maybe 10, 12 years ago, if you had severe or acute, anemia, you would go in for blood transfusion, and you normally ask family members that the same blood type to, donate blood in that. But now, as medical technology has improved, and that, so you have iron drips. So tell us the pros and cons about the iron drip as opposed to treating with conventional iron supplements. So let's just say now you are 7 or 6, right? Borderline 7 or 6. So what do you do? Do you go in for iron drip, or do you then go conservatively and take good iron medication? And also, I know every time you take iron, they say take it with combination with vitamin C, so we can maybe speak about why. And also they say avoid caffeine when you're doing taking the iron, so maybe we can just touch on that and you can just advise us. And I know, look, those iron drops, from a financial point of view, if you don't have, or you just have hospital plan or medical aid, tend to be quite expensive. But I mean, you still need to invest in your health. So when is it a good investment to then go for this iron drips or not?
Yes, absolutely. So I think you raised a few very important points, Mariam. The first one is transfusion versus conservative treatment, or versus iron therapy. So of course now we're talking about patients with iron deficiency anemia, not other causes. So when do you transfuse, and when can you consider a an iron, either an infusion or iron therapy? The most important thing is not just the HB. So if the HB is less than 7, perhaps that's one of the indications, but those other things that I talked about, age. So an older person will be symptomatic earlier, and that's what we're looking for mainly. Is somebody symptomatic? And what is symptomatic? Are they short of breath? Are they able to maintain their normal activities? Do they get tired very easily? Do they have to, for example, get fatigued and get in the afternoon have to take a nap? Are they tachycardic? Is their heart moving faster? Do they have palpitations? And do they have any underlying problems that would suggest that they are more susceptible to going into heart failure? That's the main thing. So that's the first thing we decide. Does a person need transfusion? Not, and that's not an easy answer. As I said, it's dependent on all of these things. By and large, the majority of patients with iron deficiency actually don't need a transfusion, even when their HB is 7 or 8. And the reason for that is because the majority of people develop an insidious course of the iron deficiency, and they've compensated very well. Their body is managing it, and now you can give them iron supplementation. So now we can move on to the next part. And where that question then is, do we give intravenous or iron in the drip, or do we give oral iron? Now, in the past, and this is changing now over the last few years, it was always preferred to give iron tablets or iron capsules or oral iron, in other words, non IV, non drip iron, because it was safer. Intravenous iron was associated with complications. You could get allergic reactions, and then you can get very serious anaphylactic reactions. However, in the last years, we have new formulations now that have changed that. So even though that risk is there, that risk is fairly small. It's less than 1%. So, but what I do is it depends on other things. Of course, it's very important, most importantly, what the patient wants and whether that treatment is acceptable. So we need to have a discussion. Your clinician and yourself needs to have a discussion on what is more appropriate for you. But let's go to a few maybe other basic guidelines. If the hemoglobin is generally less than more than 10, the person is not really symptomatic. They're feeling a bit tired, yes, but they're not clapped out. They're able to do their work. Then perhaps oral iron is a decent alternative if they tolerate it. Now, what about toleration? Iron can give you some side effects, and I'm sure there's people in the background saying he's saying take iron supplementation, but it's horrible. It gives me constipation. It gives me diarrhea sometimes. Absolutely. If that does happen, then we have to look at the formulation and perhaps consider even or IV iron or intravenous iron. Remember, there's different formulations of iron, right? So the oral iron generally I'll reserve for patients who are less symptomatic. Perhaps they, HBs are higher, and they prefer to take a tablet rather than go for a drip. Now, if a person is more symptomatic, the HB is perhaps less than 10, or time is the issue, or they don't absorb iron, or they tried iron in the past and the side effects were either too much or they just couldn't tolerate it, then intravenous iron is definitely an option. Now, intravenous iron, there's different forms, and the difference is that some are newer and some are older. But when we look at the ones that I would advise, the more newer ones, there's Venofer, there's Cosmofer, and there's Ferinject. These are three versions. They offer the biggest difference is the price, because the Ferinject can be given over a very quick period of time, so over an hour to 2 hours, whereas the Cosmofer takes 7 hours, whereas the Venofer you can only give 200 milligrams. So what your doctor has to do is work out the dose. And there's a formula, we call that the Ganzoni's equation. And Ganzoni's equation, we can work out how much iron you need. And on the basis of that, we can see which iron we need to give you. In terms of cost, you raised that question. Yes, it can be expensive, but again, that is a relative term. So how expensive is expensive? So the average person needing Ferinject, the most expensive one, which when you be given over a couple of hours, the medication itself, this is not the administration, of course, the administration charges, but the medication itself costs about 5,000 Rand, let's say this. The Cosmofer, which takes about 7 hours to give, generally for the average person costs around 1,800 to 2,000 Rand. And the Venofer is cheaper, but the Venofer has to be given multiple times. You cannot give one Venofer. Generally, you need to take about 5 drops of Venofer. This again depends on what the iron deficit is. So definitely it is effective. Definitely the good thing about the IV iron is you don't have to take the tablets for a long period of time, because with oral iron, the tablets, you have to take it till the anemia is resolved, and then you have to take it for 6 months later to increase the stores or to replete the stores, whereas the IV iron, you don't need that. The last point I want to make that's really, really important, and we often forget, and it's not just about taking the iron. We need to make sure we find the cause and treat the cause, because if we don't, then we're going to go back to square one. And if I may briefly say, when we talk about blood loss, and I think this is often neglected in females, is that menorrhagia or menstrual blood loss is the most common cause, and this is often neglected because females think this is my normal, and this is often a reason, and this really needs to be evaluated. And the other cause, which is also serious, is bleeding from the gastrointestinal system, the stomach, the colon, etc. And this needs to be evaluated. So it's not just, let me get my iron in the drip and I'll be fine. Yes, you will, only for a while, until it manifests again because you haven't treated the underlying problem.
Shukran for that. I think this was a really, really good segment in terms of especially understanding this anemia and how to treat it, and also what the numbers stand for. So before I let you go, 2 questions. Number one, how often can you test to see if your level has increased and come up to uh, what we call normal, acceptable? So that would be around your 12, 13. And then in Ramadan, if you are, if you know you suffer from anemia and things like that, how do you take your iron supplements? Do you take it at suhoor? Do you take it at night? So how do we then manage this? If you could just give us which is the better time to take it, at suhoor or maybe at iftar time or in the evening.
Two excellent questions. Let's deal with the second one first. And the second one is that if you're taking oral iron supplementation, when is the best time to take it? Well, the good news is that more recent studies have suggested that taking iron supplementation once a day is far better than twice a day. And in fact, there's some data which perhaps will need to be validated and hasn't been validated, that maybe every second day is better than every day. So that's the first thing, is that once a day certainly is better. So when is that once a day? Absolutely, you raised a few very important points, that it's better to take it on an empty stomach. We know this because the absorption is affected by those flavonoids, by the teas, the caffeines, etc., all of those things, and the absorption is increased by vitamin C. So it's better to take it certainly on an empty stomach. But of course, in Ramadan, that may be difficult. But what one can do is perhaps at night before they sleep, or perhaps if they're getting up early for Sahri, perhaps getting up, making tahajjud, maybe that is a better time, and then have your suhoor a little bit later. If that cannot be avoided, then taking it at Sahri time should be okay. Certain iron preparations perhaps are better than others, and I don't work for any of these companies, so I'm not going to punt them. But I like to use a medication called Sideral Forte. And Sideral Forte, I find, tends to be absorbed well. It's got vitamin C with it together, so you don't need to add the vitamin C. And that works well. For other people, Ferrimed works well. So for other people, the liquid iron works well. So there are all of these options, preferably, as I say, on an empty stomach. But if that cannot be, I would say once at suhoor or once at bedtime would be good. The second question was, how often do you test? And that depends on what the degree of the anemia is. But let's say for the average person who has an iron deficiency anemia, hemoglobin's around 8, 9, 10, perhaps 11. I would say if you're getting the treatment, even if it's a drip, I would not do the test within 6 weeks. So I would wait 6 to 8 weeks. However, if I'm not feeling improvement by 2 weeks, you should start feeling an improvement by the second week. Then I would go back to my clinician and say, I'm not really feeling any difference. Is there something wrong? Perhaps we need to test there, because then is the diagnosis incorrect? Because this can happen. Or did I not absorb the iron? Am I not absorbing the oral iron perhaps? And that's also a situation. Or am I not taking the correct dose? So if there's no improvement, yes, I would go sooner. If one is finding an improvement to see what the response is, then I would wait 6 to 8 weeks.
Tough for myself as well, and I'm sure for all the listeners out there. And then shukran for your time and informing us about blood disorders, inshallah. And thus has been brought to us by Path 24 Laboratories. Yes, at Path 24 Laboratories, if you need to have an iron test done or full blood count, um, a trusted lab to go and do this and get your results for your optimal health. I always say it's always best to be proactive when it comes to your health, because your health is your wealth. And especially in Ramadan as well, please, while we in that, I say that Urdu word, I try to look for English equivalent of the Josh, but it just doesn't come there. But while you're in the Josh, please, you spiritually, you need to take care of yourself physically as well, inshallah. And I think a healthy body, mind, and soul. Before I let you go, Professor, anything else you'd like to add to that?
No, in fact, I'd like to thank you, Jazakallah, for the opportunity for myself, both on the Pathcare platform as well, Path 24 platform as well, but to highlight this very important thing. And perhaps it gives me an opportunity to request your listeners and yourself for dua for myself, my family, our ummah, the ummah of Nabi Kareem Sallallahu Alaihi Wasallam, and those who are suffering all over the world, that Allah subhanahu wa ta'ala alleviates their difficulties, their hardships, and grants them ease. Jazakallah for the opportunity. Assalamu alaikum wa rahmatullahi wa barakatuh.
Summa Ameen. Wa alaikum salam wa rahmatullahi wa barakatuh. With that, we're going to go for a short ad break. And we next, on our next segment, conscience over convenience. Looking forward to that one.